First of all, we welcome you to the second meeting with Professor Marc Levitt about anorectal malformation. We started our meeting about regulation point. During the meeting, we will mute all participants, and the question will be written during chat, through the chat, interaction through interactive board during presentation. If you want to tell a comment, you will raise your hand to unmute. Okay, our clinical patient, our clinical case today, 8 years old girl, complaining from abdominal pain. The complaint was recurrent every 2 or 3 weeks since 1 year. The pain is colicky pain in all abdomen. Sometimes girl can focus it in right area fossa, and sometimes more severe after meals by 1 or 2 hours. The past history, as the mother says, at the age of 2 years, she was complaining from screaming and crying during defecation, and managed at that time by stimulant laxative. Now she passes stool every 2 days, and sometimes she is staining her underwear. Okay. We start the first ball now to ask about how many stools are normal for 6 years old girl or boy. Can you see the
So this patient obviously.
Dr.
Yeah.
Levitt? Yes. We will give 15.
So this patient obviously has severe constipation with symptoms such as abdominal pain and soiling. Of course, you could also have not willing to eat, chronic distension. This is significant constipation. We need to figure out why. We need to make sure the patient does not have Hirschsprung's, probably not. And then we need to treat this patient, most likely medically, but we need to know as a surgeon if we can help such a patient. So
okay,
I don't know if there's a correct answer to this question. Go ahead.
Okay. Most of our attendees select it is normal to pass once per day as a normal habit in this age.
Yes.
Okay. And by clinical examination, the abdomen was lax with mild distension, no focal tenderness, and by BR there was a fecaloma. CRB was 6 and the white blood cells is 10,000. Okay, so we will, Professor Levitt already answered for this question. But what's the possibility to think about appendicitis at that time on top of chronic constipation? Dr. Levitt? Dr. Levitt?
Yes.
How percent of patient you see appendicitis on top of chronic constipation? Or in another word, can we consider chronic constipation as a predisposing factor or causal factor for appendicitis?
Yeah, that's an interesting question. I don't think anyone knows the answer to that question. I will tell you that in the United States, the #1 reason why a child comes to the emergency room with abdominal pain is constipation, not appendicitis. So constipation is extremely common, but what you're asking me is if constipation makes it more likely that the child will develop appendicitis? I don't know the answer to that question. All right, let's continue.
This is X-ray for X-ray.
Can you move the poll? The poll is blocking the screen.
Okay, sorry. I already canceled it.
There you go.
Okay. This is X-ray abdomen standing for this patient.
Okay.
Can you comment on it?
Sure. I mean, this is a very distended abdomen, a very distended colon, and it appears to have hard stool, particularly in the sigmoid. I predict there's a large sigmoid loop, which we'll probably see on the contrast study. And it's all consistent with severe constipation.
Okay.
Okay, keep going.
Okay. Now we wanted to ask two questions. First, we ask about what is the following investigation? For my colleague, what is the following investigation should be the next step in this patient? Is it barium enema or rectal biopsy, colon manometry, anal manometry, CT with angiography? And we will share the result.
So I hope no one is still using barium. Rather, they should use the horizontal contrast. Barium can cause an impaction. If the question is, should we get a contrast study of the colon? I like to get a contrast study of the colon. I don't think at this age we need a rectal biopsy. I would do an anorectal manometry first. That's a very good screening test for Hirschsprung's disease. And in addition, it will tell you if the patient has internal sphincter achalasia, which is the same sphincter dysfunction as Hirschsprung's disease, but obviously with normal ganglion cells. If the patient has an abnormal anorectal manometry, you're going to be obligated to check for a rectal biopsy, although in a patient like this who has been growing is unlikely to have Hirschsprung's disease, but occasionally we have an older child with Hirschsprung's disease, but it's very, very rare. So I think the best thing to do is an anorectal manometry. If that's normal, you do not need to do a biopsy. It's not Hirschsprung's disease. If it's abnormal, you should do a biopsy, but it's still very unlikely to be Hirschsprung's disease. The abnormality is probably related to internal sphincter achalasia. Our routine in this patient is to do an anorectal manometry and then have the patient be awake to try to get a good result, but be in the operating room. So if the anorectal manometry is abnormal, we can then put the patient to sleep, do the biopsy, and inject Botox.
Okay, and for sure, the next question is asking about the availability of manometry at center, because I think it is not available enough, and I don't know what is the trust and the dependency on it in Egypt specifically.
So and you guys do not have anorectal manometry available to you?
Most of our disable, I will see you the result. Most of
anorectal manometry is very helpful, and you should try to get it. It's not very expensive equipment, and it requires a gastroenterologist to work with. I bet you the adults have it for their patients. I find it very helpful because it helps you decide whether or not the patient needs to be evaluated for Hirschsprung's disease, and also helps to tell you whether you need Botox.
Oh. Okay.
So there's a very good question here. What if you did a rectal biopsy and it showed no ganglion cells, but no hypertrophic nerves? So the answer to that question is always you have to repeat the biopsy, because if the only way you can diagnose Hirschsprung's is if there are no ganglion cells and hypertrophic nerves. If you don't have hypertrophic nerves, it's not a good sample. The more common situation in a rectal biopsy of such a patient is that there are ganglion cells, but there are hypertrophic nerves. What do you do in that case? Does anyone have an opinion?
Okay.
Anyone?
That's a question again. What do you do if there are ganglion cell but no also hypertrophic nerve? If someone wanted to answer, raise your hand, please. We have answer from repeating the biopsy again.
So if you have an answer, please type it at the bottom in the chat. We don't want to unmute our microphone.
We already have an answer. Repeat a biopsy.
Okay, so I don't think you need to repeat the biopsy, because if there are ganglion cells there, you can conclude that it's not Hirschsprung's. The distension, the dilation that has been caused by the constipation leads to hypertrophic nerves. So this is not Hirschsprung's if you find ganglion cells.
Okay.
If anyone really wants to talk to you, just type your answer into the chat. All right, Mohammed, keep going with the case.
Okay. This contrast study, we can ask on it.
So does this look like Hirschsprung's? Very interesting here. It looks like there's a loop in the sigmoid.
Yes, we have a loop here. But can consider it as a discrepancy. We have a dilated rectum and it's a looping here, and also dilated colon. And I think it is a shadow of huge dilated transverse colon or other colon.
Okay. All right. right, so keep going with the case.
Okay, we will ask about the following step in management.
All right, so the management of this case. The majority of the people are suggesting medical management, and I would consider medical management either laxatives or enemas. Both are medical management. The laxative plan would work only if you first empty the colon, so you have to completely empty the colon with a bowel prep, and then you need to choose a very high dose of laxatives to get this colon to empty. I bet you this will be a difficult colon to empty with laxatives. If you give enemas, that also may not tolerate, but that is also considered medical management. So either one of those is okay, and the question is, did that work? And if they don't work, then we consider this a failure of medical management. Okay, let's keep going.
Okay, and we have a last question on the case. If you select surgical intervention after failing of medical management, what will you select?
Okay, very good. Let's see what. So now we've decided that the patient soiling, they are still getting impacted, they are still having crampy abdominal pain. You have not improved them with medical management. Someone asked a question, why are we talking about HD without a proper history and examination? So we talked about that. The patient does not have a typical history of Hirschsprung's, no chronic distension, and no failure to thrive, and no episodes of enterocolitis. You still are thinking about it because it might be a whose only main manifestation is constipation, and the best thing to do is a contrast study. And the contrast study did not show Hirschsprung's. But if you're still worried, then I would recommend an anorectal manometry. And the anorectal manometry is very helpful because it will tell you it's not Hirschsprung's disease, but it might tell you that it is in fact internal sphincter achalasia, which is an important diagnosis. There are many patients that have that. And if you have it, you need to give Botox. If you give Botox, they will get better, and they will need less laxatives, and they don't need any surgery. So I think the first thing is to see, now if you don't have anorectal manometry, or either try Botox. And see work, and the enemas work, or the anorectal manometry shows, if you did it, that the patient has normal external and internal sphincters. What would then be the surgical treatment in that case? And then our options are a sphincterotomy, Botox. So why not use something that can wear off over time? A pull-through means removal of the rectum and sigmoid, which I think is a lot more surgery than this patient needs. I think you need to preserve the rectum in order to preserve continence, but I do like the idea of doing a laparoscopic. However, you need to recognize that the next option is the best option, because the vast majority of these patients will do well with only a Malone. So my advice would be, in such a case, is to try a Malone only. Even in patients who have very poor motility in their colon, and you could be scientific about it and do what's called colonic manometry, or a radionuclear study, a nuclear study to show whether the motility of the colon is normal or abnormal. Even in such cases, a Malone only works in more than 80% of cases. It's not common that you need to do a resection. So what I would do in such a case is I would do a Malone, and then I would do flushes, antegrade, and see how the patient has done. And if the patient does well, you might be done. And if the patient still has trouble emptying despite a very large volume or a very concentrated flush, that's the patient you can discuss doing a colon resection. And such a colon resection would require removing the part of the colon that's not working. So ideally, it would be the part of the colon that you have studied with either colonic manometry or nuclear medicine. Do you guys have colonic manometry?
No. No.
Do you have nuclear medicine studies? Do you have nuclear medicine studies for the kidney and for other purposes?
Yes.
Okay, so you can use the nuclear medicine study to study the colon. And Mohammed, if you send me an email, I will send you the nuclear medicine protocol of how to do a nuclear study of the colon. It's a very good motility test.
Okay.
It's very easy to do, and I bet your nuclear medicine doctors will be happy to do it for you. Basically, you want to know one of three things. You want to know, is the motility normal? Or is the motility abnormal in one section of the colon? Usually that's the sigmoid. Or three, is the motility abnormal for the entire colon? Luckily, the last one is very, very rare. If the motility is normal, the Malone should work. If the motility is abnormal in the sigmoid, the Malone will work more than 80% of the time. If the entire colon is not working, the Malone sometimes works, but usually does not. I will give Mohammed the protocol for the nuclear medicine, and then he will share it with the group. I can't find it in 2 seconds and give it to you.
I think we finished our case now. If you wanted to share some slides.
Some slides. I have to share my screen, right? How do I do that? Any idea how we do that?
Yes, from right side, you share a screen. You have a button, green button, share screen.
Share screen. Okay.
Yeah, at the middle of the toolbar, you will find the green button, share screen, and you can, yeah.
So now you see my screen, right?
Yes,
Yeah.
yes.
All right, I'm going to find something good here. Okay, so let's do this. You see this picture?
Yes.
Isn't this cute? Look, the pizza goes here, the teeth, stomach acid, the liver, pancreas, gallbladder, and the colon. You see it?
Yes.
Can you see it?
Yes. Yes.
Okay. So basically, we talked about much of this. This is the anorectal manometry. This is what it looks like. There's a probe that goes into the rectum, and it detects the resting pressure and the presence of a recto-anal inhibitory reflux. And can the patient expel the stool? It does a push test. And this is what this looks like. You can see whether there is appropriate relaxation associated with stool in the rectal vault. I'm going to skip this. This is what colonic manometry is. The probe goes into the colon, and then every time you see one of these nodes, you can record the peristalsis, and you can detect whether there is normal or abnormal peristalsis. And it looks like that. See how the HAPCs propagate through the various parts of the colon. That's normal. So this is abnormal. You can see there's a flattening here where the sigmoid has no HAPCs. Okay. See? Colon is good. Sigmoid is quiet. And the rectum is always quiet. So this is a patient who has no HAPCs in their sigmoid colon. Okay, this is the nuclear study. Look at this. You can do this in your own hospital. This is normal. See, the tracer got to the rectum and stopped. And you can again, you want to know normal. Is the sigmoid or another segment abnormal, or is the entire colon abnormal? Okay, so now, let me show you. Here we go. So this is a patient. This is a very impressive patient that would do well with Malone only. And this is a diagram which shows a sigmoid resection with the Malone in place. And again, only if the Malone only doesn't work would I recommend a sigmoid resection. Okay, let's talk a little bit about the Malone. You can do a Malone with a hidden orifice in the umbilicus, or you can do a cecostomy using a tube. Now we have a nice tube that has a balloon, so you don't need to use this Chait tube. What I like to do is I like to make a Malone and then the family can choose, do they want to cath once a day, or do they want to leave a tube inside? Here's what the cecostomy looks like with the laparoscopic view. And here's the Malone. Here's the cecum is wrapped around the appendix. Do you see that?
Yes.
Like a plication. And here are two types of appendixes. Sometimes the mesentery parallels the appendix, and you can do the wrap like this. Sometimes the mesentery is fenestrated, and you have to put it through the mesentery so you don't injure the mesentery of the Malone. And then some patients have no appendix, so you can make a flap and make what's called a neo-appendix. Like that. We have these dolls in the clinic so we can have the child feel comfortable learning what it's like to pass a tube into their own belly button. So let's summarize. Can you see this screen?
Yes.
So here are the 6 types of patients. You have someone who is failing to thrive with diffuse dysmotility. That's a patient that I think needs an ileostomy to get them to recover, and then maybe a Malone. B, their sphincters are abnormal. That's a patient who needs Botox and or biofeedback. This is, again, patients who have failed medical management. Either they failed laxatives or they failed enemas. Okay, if you have a normal anal sphincter, but the colon is abnormal, you can provide a Malone and recognize that you might need a resection. But as I said, most of these patients do not need a resection. They respond to Malone only. Now, if you have a patient whose flushes are not working, then you need to do an assessment of their colonic manometry. And in our case, we do colonic manometry with a motility study, but you can do nuclear study as we talked about. And then if there is segmental disease, they get a segmental resection. If there is diffuse disease, they get an extended resection. And I'm going to show you what that looks like. Again, that is for patients who have the entire colon is not working. And then just to complete the discussion, we have something called sacral nerve stimulation, which can improve urology issues, but also can improve the antegrade flush. So I'm going to show you this idea I have about an extended resection. Here. So this is the idea. If the entire colon is not working, we can keep the right colon and anastomose it to the rectum. Like this. Here's the rectum, and here is the residual right colon with a resection of all of this. Again, this is for diffuse dysmotility. Okay?
Okay.
So just so you know, we have, looks like 80 participants. Very good.
Yes. We have about 20 minutes for the discussion. If anyone wanted to have a comment or ask a question, please raise your hand.
Any questions?
Okay, we have one. Mustafa.
Mustafa has a question.
Yes, we will unmute.
Dr. Mustafa?
Hello, hi, Malek. How are you doing?
Fine.
Hi, Marc Levitt. How are you doing? It's just a quick question about the inrectal manometry. I always find the results would be a bit dodgy if you have a mega rectum. Do you have any tip about the balloon? What size of balloon do you use? Does it change with age? What's the tips here about that?
Yes, I agree that that's a bit of a problem if the rectum is very dilated, but you really want to know, you may not be able to get a good result from the push test, but you should be able to get a result from the anal canal. You want to know what's happening at the anal canal.
Okay.
I do this in conjunction with our gastroenterologists. They are really the experts on anorectal manometry.
Okay. Okay. All right.
But you are welcome to send me an email, and then I can engage them in the conversation that you have about the patient.
Dr.
Does
Sama,
everyone know my email?
I think you know you can type it on chat.
Can you see? No, you can't see that, can you? Anyway, Mohammed will give you my
Okay.
my direct email.
Professor Sama, you have a comment?
There are more questions.
Yes, yes, Mark, thank you very much. That was very interesting discussion. This is Samah Shahata.
Sammy,
Yeah, hello.
nice to see you.
Yeah, we wanted to see you physically in Alexandria, but unfortunately, we have to see you online only.
You know that Sammy, I was going to bring to Alexandria my Sammy. I have a 23-year-old son named Sammy.
Really? That's very nice. I would like to see him.
And he was coming. He was coming to the meeting, but unfortunately it got canceled.
Hopefully.
What is your question?
Yeah, in cases when we don't have isotope transit studies, I used to do contrast enema, and I would like to look at delayed films at 48 hours. And this will give me a very nice characterization and difference between two patterns of slow transit. One of them is you can see the whole barium or contrast inside the colon, and another one where you find everything in the rectosigmoid. So you have two different patterns, one total colonic inertia and one rectosigmoid inertia. And I have compared this with results from, I try to show you some of these x-rays now, if I can share it from here, and tell me what you think.
I like the idea a lot. I just think everyone needs to recognize that the contrast study might look like a very bad colon, but amazingly, the colon might respond to only Malone flushes. So please don't remove a colon because of how it looks on the contrast study. You need to correlate a physiology of that colon. So Sammy's idea is a very good one. If there is still contrast 48 hours later, that is a pretty significant dysmotility. If it washes out within 24 hours, that's much better motility. But just because the colon is dilated does not mean it needs to be resected. I used to remove many more colons. Now I almost never have to remove a colon. I always start with a Malone first, and then if the flushes don't work for 3 or 4 months, then I go ahead and do the resection.
Can you see this, Mark?
Yes, beautiful.
Yeah, this is intractable constipation, failed conservative treatment for more than 12 months. And this is a picture after 24, 48 hours. As you can see here, the whole colon is filled with contrast. I'll show you another one now where you can find it markedly dilated rectosigmoid, and you find the contrast in that region.
Yeah.
So this is my message and my point.
So based on this result, you would do a resection?
If it complies with the definition of intractability after aggressive management, it will dictate the choice of my surgical management. Of course, this
Yes, I agree. I agree with you. The only thing I want to add to this is really what's new, and we have now data, more than 60 patients we have documented dysmotility in the sigmoid, and yet we still only did a Malone. And in more than 80% of the patients, the Malone was enough. Very important.
So
only do a resection. Go ahead.
We can add to the algorithm that before going for surgery, we can give a period of trial for the Malone.
I agree. I agree with that.
Okay, we have more attendee to speak. Dr. Shif
We have some more questions.
Yes. Dr. Shif Shahada.
Dr. Sharif. Okay, Dr. Saber.
Yeah. Hello, Professor Mark. I want to ask some questions, 3 or 4 questions. I believe personally that the pathophysiology of the functional constipation in children or even adults, either in adult functional constipation, either it is a continuation of pediatric functional constipation or started de novo. My first questions, are you believe that the beginning of the functional constipation in school age group, it is a continuation of fecal disorders, especially painful defecation at age from 2 to 4 years, or these conditions can start de novo at age of 6 or 9 or even adolescent? You know that the theory of painful constipation leading to the visual circle, which is suitable for the pathophysiology of the reflex arc mechanism and what the scientific facts or the basics of defecation or evacuation. And this will lead to the classification, either it is a slow transit constipation or obstructive or evacuation disorders. I want to know, you believe that it is, the history is like that, or it is related in some conditions, this functional obstruction related to neuropathic or myogenic disorders?
Well, I have seen both types. Certainly, most patients start developing constipation when they are young, and they never get medically managed, and then the colon gets bigger and bigger and bigger, and eventually they have a serious problem that needs to be intervened on. But I've certainly seen other patients that never had a problem with constipation, and then suddenly at the age of 9 or 12 or something like that, 14, they start to develop constipation. I like the distinction that you made. Either it's the colon that's moving too slow, or the outlet, the sphincter in the pelvis, is causing a problem, or both. That's why I think it's very important to assess the outlet. There are patients who have an outlet problem only that will not get better with surgery. They need biofeedback or Botox. There are other patients that have a colonic transit problem, but no sphincter problem at all. They need treatment of the colon, either with laxatives or a Malone. For them, biofeedback or Botox will not help. And then there are some patients that have both problems. So I like the way you characterize that.
Dr. Mark, we have a question on chat. When do we say that Malone has failed in treatment?
Yes, that's a very good question. When has the Malone failed? First of all, I want to be sure that you're giving a good flush. A good flush would mean, in my opinion, maybe 500 cc's of saline and something else, like additional 30 cc's of glycerin, and maybe in addition to that, 20 cc's of a soap, the shampoo. That's a strong flush. If the patient still does not empty and has obstipation, has obstruction, has impaction, you can conclude after several months that that is a failure. That's a patient who then needs motility testing, however you'd like to do it. If you want to do the SAMI way with the contrast enema and checking an x-ray 2 days later. If you want to do nuclear study, which we'll send you a protocol for, or if you want to do colonic manometry, if you ever are able to get that modality in Egypt. And then based on that, you do a resection, usually sigmoid resection, occasionally an extended resection like I showed you.
My second question, please, Mohammed.
Dr. Saad, we have, okay.
I want to ask.
So Professor Sharif has I would like to be unmuted.
Mark, my second question, please, is are you consider the soiling or encobraces is a significant for the severity of defecation disorders? And if it is a primary, usually, or it is a sequelae for the severity and long-standing, regardless the duration of onset of the soiling or the time interval between every motion?
Yes, I think if a patient has very bad constipation to the point of soiling, that is a severe problem. That is a severe problem. Usually it's secondary. Usually the constipation was bad, usually from an early age, and they kept getting a bigger colon and a bigger colon, and then they started to have soiling. So someone asked about the technique for Botox.
Yes.
So the technique for Botox, what I do is I take 100 units of Botox, I draw it up in, I put it into 1 cc of saline. Now it's very important that when you have the little vial of Botox, you open the top and then you gently pour in the saline, because the Botox is a powder that is on the very bottom of the glass vial. Don't shake it. Slowly stir it so that it absorbs the powder, and then draw that liquid up 1 cc into a very fine syringe. Then with a small needle, I inject exactly at the dentate line, perpendicular to the anal canal, so perpendicular, and maybe 2-3 millimeters in 8 positions. I don't use ultrasound, but I have used it. It's very elegant, but I feel that I can do it and put it in the right place without ultrasound.
Dr. Sharif, حضرتك معنا?
The question is, there's a question, in the absence of reliable manometry, can we use Botox as a therapeutic test? Absolutely. It is both diagnostic and therapeutic. And if you don't have an anorectal manometry to guide you, I would still try, because it might help a patient and then they get better just with the Botox.
Dr. Ahmed Khairi?
Yes, I just want to ask a question. In cases of Maloney, do you always have to make the wrap? You cannot bring the appendix without wrapping?
What's the question? Sorry, say it again.
In Malone procedure, do you always have to make a cecal wrap around the appendix? You cannot bring it out without wrapping?
Well, about maybe 10 years ago, I read several articles that said you do not need to plicate the appendix. So I decided to do my own study. I took the next 10 Malones and I did not plicate. And would you like to know how many of those leaked?
Yes.
5. 5 leaked, 5 did not leak. And based on that very minor series of only mine, I said, I'm just going to do a plication, because now when I do a plication, it never leaks. So my preference is to do a plication.
If you have if you have Mark, if you can send to by Muhammad through the group a short clip for doing Malone and the skin part of it, and you know, the plication part, and we do normally do through laparoscopy or by open or what?
Yes, so there's a very nice video of this. If you go to expertsinsurgery.com, expertsinsurgery, one word.com. I do the plication through the umbilical incision. So what I do is I put in a laparoscope into the umbilicus. I then make sure the right colon is mobilized. That's usually 5 minutes. And then I make an incision on the infraumbilical fascia only. And then I remove the cecum out of the incision. I make my plication. I put the cecum back in, and then I connect the umbilicus to the tip of the appendix. Sometimes you have to shorten the appendix a little bit because it's too long. There's a very nice video of that. I'll write it here. Experts.
Thank you. Thank you very much.
Muhammad Abdulazim.
All right, I think we have time for one more question.
Yes, Mark. My question is, do you see Malone as a temporary procedure or a permanent procedure? And when do you...
Usually temporary.
Okay, so when do you undo it to reverse it? When?
So I have only had to reverse it twice. Because if you stop using it, the hole just closes on its own.
Okay.
Nothing to do.
So for how long do you keep the patient Malone? Anyways.
I usually make the family commit to at least a year. A year.
Okay.
And then you can try laxatives again.
Okay, and they work after you stop using them alone.
Well, they may better respond to laxatives at that point.
What about the size of the colon? Does it reduce after you've used them alone?
Yes, I think the size of the colon does reduce.
Okay. Cool. Thank you.
دكتور شريف حضرتك
شكرا
معانا؟
مايك.
ايوه سامعني يا محمد. Do you hear me?
اتفضل.
Hi Mark. Excuse me, I have two questions for you. The first, do you use saline only for the Malone as a wash or another formula? And the second, from the cases you have been excised of the sigmoid, what is the histopathology regarding the alpha smooth muscle actin and the fibrous tissue involvement in the wall of the colon?
Yeah, so for the enema, I usually start with 500 cc's of saline with 20 cc's of glycerin. That's a good start. And then you can do changes to that based on the results. You can give a little bit more glycerin. For a patient older than the age of 4, you can use water. The saline is a little more provocative, a little stronger than water. but every time you need to change it a little bit to try to get the flush to work better, and I correlate that with an X-ray. So if the X-ray shows that the colon is empty, that means the flush that you chose is a good flush. If the X-ray shows that there is accumulating stool, you need to give a stronger flush. With regard to the pathology, our pathologists have really not seen much other than thickening of the muscle. I think we need to do a lot of work in the histopathology to try to figure out what's wrong with these patients, but at the moment we really don't understand it. So out of respect to everybody's time, we want to keep these meetings exactly 1 hour. Now it is 2 p.m. in Washington, D.C. By the way, it's so far it's been quiet here. We are waiting in the next week or so for an increase in our cases, but it seems that the children, luckily, are not being very effective. We have about 10 to 15 patients in the hospital with the virus, and that's about it. And I wish all of you good health, and we will see each other next Thursday, inshallah.
Inshallah. Thank you. Thank you for attending.
Very short question. Yes, Mark, did you recommend the barium enema after evacuation or before evacuation? Second questions, are you prefer rectosigmoidectomy, transanal or transabdominal with or without assisted laparoscopy?
Yeah, I don't think it matters when you give the contrast study. I like to just give it because it helps to empty the colon. And I don't do transanal. I want to do a low anterior resection. I would like to save about 6 centimeters of the rectum.
Transanal or abdomen?
Laparoscopic.
Laparoscopic, yes.
All right. See you all, everybody next week.
Thank you. Thank you all.